Yeah, Dr. O is going to present on Parkinson's disease.
Oh, yes.
Can I start?
Yes.
Okay. Good morning, everyone.
Good morning. Good morning.
My name is Dr. Onwudiwe, and I'm going to be presenting Parkinson's disease. I'm going to follow this outline. So Parkinson's disease is a neurodegenerative disorder that affects predominantly dopamine-producing neurons in the substantia nigra. It's a progressive disability that can be slowed but not halted by treatment, and the symptoms generally develop slowly over years. And progression of symptoms is often a bit different from one person to another because of the diversity of the disease. In terms of epidemiology, Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's, and typically develops between the ages of 55 and 65. It's higher among women with a ratio. It's higher among men than women with a ratio of 1.5 to 1, and more common among whites than those of Asian or African descent, although we have conflicting data on that. The exact cause is unknown, but is assumed to be the result of a combination of environmental influences and genetic predisposition. And there is increasing evidence that genetic and environmental insults lead to Parkinson's disease, commonly lead to abnormal forms of the normal protein. The main, okay, I'll go talk about that in pathophysiology. And the normal protein alpha-synuclein is the major thing that contributes to cell death in Parkinson's. So we have risk factors, modifiable and non-modifiable, and the non-modifiable ones include age, male sex, and genetics. The Parkin mutation is seen in juvenile onset, and the LRK2 mutation is the most common mutation, which leads to increased alpha-synuclein, and which activates the brain macrophages called microglia and leads to cell death. It has been posterized. Increased risk include industrial exposures, heavy metals such as manganese, pesticides, and probably obstructive sleep apnea in women. And some studies have shown decreased risks in patients who smoke and patients who take caffeine. Although I'm not sure why the data on smoking is out there, because it seems like the risks outweigh the benefits in the long run. Okay, the two major neuropathologic findings in Parkinson's disease are loss of the pigmented dopaminergic neurons in the substantia nigra and the presence of the Lewy bodies. The Lewy bodies contain the alpha-synuclein, which activates the macrophages, like I said. And the primary biochemical defects are the degeneration of dopamine-producing cells and hyperactivity of the cholinergic neurons. And then, based on pathologic studies, there's a stepwise degeneration of neurons over many years, and for each site where the neurons are being lost, it corresponds to a specific symptom in Parkinson's disease in a table I'm going to show next. And then by the time the motor symptoms become evident, there's a 30 to 70% cell loss evident in the substantial nigra on pathologic exam. So this is the table I'm talking about. By the time there's Lewy body accumulation and loss of dopamine neurons in the dorsal motor nucleus of the vagus nerve and olfactory tract, the symptoms are constipation and anosmia, which precede the motor symptoms by up to 8 to 10 years. And then in the locus cerealis and subcerealis complex, it affects the sleep and mood, it causes sleep and mood dysfunction. By the time we have sites Lewy body affectation in substantia nigra, then motor symptoms of Parkinson's disease become evident. And by the time there's cortical involvement, then we see the symptoms of dementia and psychosis. These are the this is a slide showing the Lewy bodies. Autonomic dysfunction has been related to deposition of Lewy bodies outside the brain, including the spinal cord and peripheral autonomic nervous system. So this is a slide. This is showing direct and indirect pathway of motor coordination and how it leads to Parkinson's disease. So the direct pathway is stimulated by dopamine to cause movement, and indirect pathway is inhibited by dopamine to, indirect pathway causes reduction in movement. So for movement to take place is inhibited. and movement continues. But in Parkinson's disease, there's no dopamine to stimulate the direct pathway and to inhibit the indirect pathway, and so we have slowing of movement. Okay, clinical features. The initial clinical symptoms include tremor, bradykinesia, rigidity, dystonia, subtle decrease in dexterity, decreased arm swing, soft voice, decreased facial expression, which is due to decreased blink rate, and sleep disturbances. We also have REM behavior disorder, in which there's loss of normal eutonia during REM sleep. And in a study, 38% of 50-year-old men with REM behavior disorder and no neurologic signs went on to develop Parkinson's disease. There's also decreased sense of smell, hyposmia, and autonomic dysfunction like constipation, sweating, sexual dysfunction. Then there's depression, slowness in thinking, and general feeling of weakness. In a British study, the frequency of the non-motor symptoms in 159 patients were found to be significantly greater than in 99 healthy age-matched control. And the most commonly experienced non-motor symptoms in patients with early Parkinson's were excessive saliva, forgetfulness, urinary urgency, hyposmia, and constipation, which I mentioned that it can precede the development of motor symptoms by up to 8 to 10 years. This is a picture showing the summary of the clinical features in Parkinson's disease. Diagnosis is usually clinical and it's based on features from history and examination, and over time based on response to dopamine agents. There are no laboratory biomarkers, and findings on routine MRI and CT scan are usually unremarkable. However, I've found radionuclide imaging modalities like PET scan and SPECT using a dopamine transporter ligand have become the best approach to assess dopamine metabolism and deficiency. And it was noted that the tracer uptake is reduced maximally in the posterior or dorsal striatum in patients with Parkinson's disease. The diagnosis criteria of the UK Parkinson's Disease Society Brain Bank is the most common criteria used and includes bradykinesia and at least one of the following: either rigidity, resting tremor, postural instability, not caused by primary visual or other dysfunctions, and exclusion of other causes of Parkinsonism, such as drug-induced like antipsychotics, infectious causes like neurosyphilis and other toxins. Then at least 3 of the following supportive features: unilateral onset, persistent asymmetry, primarily affecting the site of onset, resting tremor, which disappears with action, excellent response to levodopa, progressive disorder, then clinical course of 10 years or more. In management of Parkinson's disease, the goal is to provide control of signs and symptoms for as long as possible while minimizing the adverse effects of these drugs. And studies have demonstrated that a patient's quality of life deteriorates quickly if treatment is not instituted at or shortly after diagnosis. The main cornerstone of symptomatic treatment of Parkinson's is levodopa therapy in combination with carbidopa, and it provides the greatest symptomatic benefits, the fewest adverse effects. So this is a medication summary of the drugs used to treat Parkinson's. So we have dopamine precursors like levodopa and dopamine agonists, pramipexole, which are the non-ergot combinations that are preferred to the ergot combination of AMIQT. We also have, there's this is a diagram showing at which point in the brain each of these classes of drugs work. So the catechol methyltransferase inhibitors inhibit the breakdown of dopamine in the peripheral system, so there's more dopamine to come to the brain. So also the carbidopa and drugs like amantadine increase the dopamine availability in the CNS. We have other therapies for patients who don't respond to this who don't respond to levodopa and carbidopa and other therapies after a long time. Therapies like deep brain stimulation have been shown to reduce motor symptoms in some patients, and some good candidates for deep brain stimulation include those that are less than 70 and those that have medication-resistant tremor and also reasonable cognitive function. Poor candidates include those with severe autonomic dysfunction, severe dementia, and also have called dopaminergic response. Levodopa carbidopa intestinal gel is given via percutaneous tube in the jejunum, and it's used for patients who have motor fluctuations with Parkinson's disease with the oral formulation of it, and it has been shown to have less GI side effects, and patients have tolerated it well. The prognosis, the life expectancy is decreased in Parkinson's disease, and although the progression is slower in early onset disease, and there's longer absolute survival, but it comes at the expense of years of life lost. And late onset disease associated with more rapid disease progression and cognitive decline, which may be related to the lack of compensatory mechanisms against cell death. And prognostic factors are summarized in the next table. So predictors of a more favorable prognosis are Parkinson's disease that has early onset tremor predominant and female sex. And predictors of a worse prognosis are late onset male sex, predominant gait difficulty, rigidity of bradycardia as first symptom, dementia, poor response to levodopa, and other associated comorbidities. This is the modified Hen and Yar scale, which is used for prognosis in Parkinson's disease. So those with early onset Parkinson's disease, that's between the age of 21 and 50, usually take a longer time to get to stage 3 and 4 of this scale. In summary, Parkinson's disease is the second most common neurodegenerative disorder after Alzheimer's, and it remains a clinical diagnosis. Factors such as symptom severity and degree of functional impairment should be taken into account when choosing treatment, as well as patient preference, and levodopa remains the gold standard therapy. Motor fluctuations will develop 5 to 10 years into the disease, and surgical therapies, including deep brain stimulation and levodopa carbidopa intestinal gel, will be offered to patients who have troublesome motor fluctuations. These are my references. Thank you.
Thank you.
Thank you so much. Can you clear your screen so we can all see each other again?
Yeah.
Great. Dr. Burnett.
He's away for the first patient.
That was an excellent presentation. Very clear. What's this intestinal gel? Is that something you put through the rectum?
Yes, you put it through the rectum to the jejunum. So it gives it's the same amount you take orally, but it gives less side effects. And for those who have failed oral therapy, it gives a concentrated dose, which now helps to reduce all the motor fluctuations in Parkinson's disease.
I wonder if they have any new bacteria in the biome that can maybe reduce this, or perhaps in the future. I didn't think out of the box, but bacteria designed to create dopamine that's sitting in the gut.
Okay. I haven't seen that.
Well, that's a very clear presentation. I really appreciate it, and we have a copy for you to present for your own use.
Thank you.
Thank you so much. I wish Dr. Burnett were here. We will get him to talk later about Parkinsonism.